All right. Good afternoon, everyone, and welcome to the Public Health Science Echo, where the public has the opportunity to ask science-based questions for our public health team. This session is produced and facilitated by UAA's Alaska Echo Project in partnership with the Department of Health and Social Services. My name is Erin, my pronouns are they, them, and I'm with Project Echo. For those joining us on Zoom, questions may be entered into the Q&A feature. For those joining us on Facebook, please add your questions in the comment section and they'll be shared with our panelists. As a reminder, we do expect all participants to keep questions and comments on topic, to be considerate, and use language that is respectful. So for that, I thank you. If your internet connection does not support audio, you may join us by phone by calling the phone number we've entered in the comment box along with the meeting ID. Closed captioning is available as well. You can access this by selecting the CC button on the bottom of your Zoom screen. Thank you to our captioner. I'd also like to note that the opinions expressed in this session are those of the speakers and do not necessarily represent those of UAA, DHSS, or any of our ECHO sponsors. Our hub team should all be familiar faces by now, so in an effort to maximize our time together today, we'll go ahead without introductions up top and instead let our hub team members introduce themselves individually during this session when addressing questions. So without further ado, hub team, I'll hand it over to you. And Dr. McLaughlin, if you give me about 15 seconds, I will be sharing the slides.
Sure thing, Erin. Thank you so much. Really appreciate everybody joining us today. So we'll just wait for the slides and I'll try and go through the slides as quickly as I am able so that we have maximal time for Q&A at the end. I know there are always lots of really good questions that come up on this echo. And just so you know, we actually really look forward to these echoes. There are opportunity to hear from you, questions that you have. So these are, I think everybody on the team really enjoys being a part of these and really appreciate your attendance. Okay, so let's go ahead and get started with the brief intro here. So as you can see, almost all of Alaska is currently in the red. We are experiencing very high levels of SARS-CoV-2 transmission. Almost all of this is due to the Delta variant here in Alaska and nationally. I think on the national call that CDC gave on Monday, the 99% of all of the cases that are sequenced are coming back positive for the Delta variant. Total resident cases, 85,358. We have had an increase of about 13 cases from last week, so we're definitely still on the upswing. Hospitalizations now over 2,000 and reported resident deaths 435. Next slide, please. Okay, here's our hospitalization dashboard. Probably the most important thing to look at is the figure on at the bottom there. You can see that our hospitalizations are now on par with the peak that we reached in December and January of 2021. Currently hospitalized 161 and folks hospitalized with COVID-19 about 17%. And then total number of people on a ventilator is 20. Okay, next please. All right, Jean, I think you were going to go through the next couple of slides on healthcare capacity, so I'll turn it over to you.
Sure, thanks, Dr. McLaughlin. For everyone else's awareness, I'm Gene Wiseman. I'm the Section Chief for Rural Community Health and been assigned to keep an eye on hospital capacities and helping with some staffing issues and things like that. So what we're seeing right now with the COVID admissions increasing, we're kind of here again, right? So we're looking very similar to where we were at last year in the October timeframe with some differences. We're seeing increased admissions in a younger age bracket, I believe it's the 40 to 69-year-old, as well as pediatric admissions. The other stark difference is we have all comers now. Back in October, there's mitigation efforts and things, and it was the hospitals were it was more COVID centric, and given this time of year, we've got our typical summer activities where we see the increase, and that is all compiling in on the hospital admissions. Compounded on that, we have an exhausted workforce that they're fatigued. They've got COVID fatigue. We're short. The hospitals are experiencing short staffed, and again, the busy summer. So some of the areas that we're seeing some issues are in decreased specialty care. We're trying to load level through our hospitals, and with the specialty care issues with or making connections with like dialysis, pediatrics. So we've got a close eye on that. Decrease urgent care. So the processes are longer to get sent into the hospital. So we're seeing longer wait times in the emergency rooms and whatnot, and then decreased ability to transfer patients. And so that's where our work is with trying to load level and equalize our hospitals. Next slide, please.
Okay, Gene, I guess this one's mine. So thanks so much. Just a reminder that your actions make a difference. This is something that we all need to play a role in terms of preventing transmission of this virus. The number one thing you can do to help our community, help our state get this virus under control is to get vaccinated. That is the number one thing you can do. Also, masking when you're around other people who are outside of your household or your small social bubble, especially when you're in indoor situations, public settings. Also distancing, keeping your distance, maintaining at least that 6-foot distance from others in public settings, and watching out for symptoms. And if you do develop any symptoms of COVID, to please go ahead and get tested. And just make sure you're staying healthy in all sorts of ways. Also, if you do develop COVID, you test positive, we really want you to call your own contacts. So again, going back 2 days prior to symptom onset, notifying anybody you were in close contact with during that time period up until when you went into isolation. We do still want you to isolate if you're positive, regardless of whether or not you've been vaccinated. If you're positive for COVID, you need to isolate. It's a 10-day isolation period, and we know that you can transmit the virus during that isolation period, and so we want you to maintain that isolation to prevent transmission to others. And we know that with the Delta, it's even much more transmissible than prior strains, and so it's even more important to go ahead and isolate if you're positive. Next slide, please. All right, here's COVID-19 testing statewide. Our percent positivity is 7.5%. Again, as I think we've mentioned many times on this echo, we want that percent positivity to be down below 5%. So more testing is needed to make sure that we're really getting a handle on all the cases that are occurring in Alaska. So just want to really encourage people to get tested. Next slide, please. All right, this slide is really just showing that the Delta variant is the #1 predominant strain that's circulating in Alaska and nationally as well. As I mentioned, 99% of the positives that have been sequenced on the national level have been Delta, and that's roughly true in Alaska as well. Next slide, please. Here's vaccine breakthrough cases, just to show that the epidemiology is changing a little bit. From January through July 2021, you could see that 10% of cases were among vaccinated people, and 90% of cases were among unvaccinated people. 8% of hospitalizations among vaccinated, 92% of hospitalizations among unvaccinated. Now, if you look just at July, that's changing. So we're seeing more hospitalizations and more cases proportionally attributed to people who have had prior vaccination. This is due to a number of different reasons. Part of it is we're seeing a larger proportion of the population that's fully vaccinated. So as that proportion increases, you're going to expect to see more vaccine breakthrough cases. Also, as we've been relaying, there is waning immunity that occurs over time, and we're just now starting to get a better understanding of this waning immunity. And this is why the Advisory Committee on Immunization Practices is looking at booster doses for people who have been vaccinated. And we don't know at what point the booster dose is going to be recommended. Is it going to be after 5 months after your vaccination series? Is it going to be 6 months after the series or 8 months after the series? We don't know the answer to that yet, but it's likely that booster doses will be coming very soon. And the date that we've heard is September 20th, but more to come on that as more information becomes available. Next slide, please. Okay, here's COVID vaccinations in Alaska. 60.9% of residents with 1+ dose. These are eligible residents 12 and over, and residents who are fully vaccinated 12 and over 55%. We need to continue to move this dial up as high as we can get it. And we did notably see an increase recently. 43.6% increase compared to July 21 through August 3rd. So we are seeing an increase, but we need that increase to be higher and faster. So whatever you can do to help promote vaccination in your community, among your family members, your coworkers, whoever it is that you interface with, we'd really appreciate it. Okay, next slide, please. COVID vaccination rates by age group and region. You can see that we've got really high rates in some regions, like the Aleutians East Borough, 83%, Aleutians West, 67%, and then some that are very low. I'm looking at Southeast Fairbanks census area at 29% for all ages. So we've got a lot of work to do in some of our communities. Next slide, please. Help stop the spread of COVID. And, you know, I think, let's see, if you test positive for COVID-19, obviously we talked about isolating. If you're exposed to COVID-19 and have no symptoms, get tested and quarantine. If you're unvaccinated, if you're vaccinated, get tested and monitored. Make sure you're wearing a mask until you get a negative test result back. If you're exposed to COVID-19 and have any symptoms, we want you to get tested and isolate regardless of whether or not you're vaccinated. And if you have any symptoms of COVID-19 and no known exposure, again, get tested and stay home. Okay, next slide, please. All right, the Pfizer vaccine is now fully approved and licensed and recommended. The FDA has licensed the vaccine for people age 16 and older. It's still in emergency use authorization for kids age 12 to 15. The Advisory Committee on Immunization Practice followed up after the FDA licensure with a recommendation for the now licensed vaccine. And so hopefully this instills further confidence in the vaccine and will encourage more Alaskans to get vaccinated. Next slide, please. All right, we've talked about this a little bit. The third dose of an mRNA vaccine for immunocompromised people. These are people who have moderate to severe immunocompromising conditions. If you're not sure whether or not you have one of those immune compromising conditions, please consult with your healthcare provider. Anybody who's in this type of a situation who's already received 2 doses of an mRNA vaccine, they are currently eligible to get a third dose in that series to make sure that their immunity is maximal against COVID. Next slide, please. Now, the booster dose, we talked about that a little bit. This is for to address waning immunity in the population in general. And as I mentioned, we hopefully will hear more about the pending booster doses soon. Likely won't be available until September 20th. for people who have had 2 doses of the Pfizer or the Moderna vaccine. Next slide, please. All right, Coleman, do you want to talk about monoclonal antibody treatment?
Sure, yeah, so we're really pushing out a lot of education about monoclonal antibodies. Monoclonal antibodies are the only treatment proven to be safe and effective in treating patients who are not admitted to the hospital for COVID-19. These are injections. They're synthetic antibodies that are either given subcutaneous or intravenously. They give your body antibodies to help your immune system fight the infection. They're best given if given early. So really they should be given the closer as possible to the moment you test positive and start developing symptoms, the best chance they're going to have at proving effective. The longer you've had COVID, to the point of even people who are in the ER about to be admitted, they're not an effective treatment and they're not recommended, or for hospitalized patients. Get a lot of questions about these. They are not a replacement for vaccination. They're not as effective as vaccination, and they need to be given really in that narrow window to be effective, but they are beneficial in preventing patients from progressing to severe disease and requiring hospitalization. So it's a good treatment option. I encourage anybody who tests positive, has mild symptoms, or anybody that's high risk and exposed, please reach out to your medical provider or call our state hotline that's been updated from a vaccine line to a vaccine and monoclonal line to find out if you could get access to these drugs.
Great, thank you, Coleman. Okay, next slide, please. And this is a slide we put up every time, how to find a COVID-19 vaccine provider. You can always call that COVID vaccine helpline at 646-3322. And there are other numbers and resources available on this page. Okay, next slide, please. All right, remember to layer your protection. Vaccination is the #1 best tool that we have to curb the transmission of this virus, but there are other things you can do as well. Social distancing, avoiding crowds, masking, all these things that we've been talking about, getting tested if you're symptomatic. So really appreciate all the work that you all are doing. I know this has been a long haul, and it's unfortunately we're in the middle of another surge right now, so we need to really double down our efforts to get this under control. So everything that you can do as individual citizens of Alaska to help control the spread of this virus, we really appreciate. Okay, let's go ahead, Erin, and open it up for Q&A.
All right, excellent. So this one's touching a little bit on monoclonal antibody treatment, namely, where can small Alaskan communities get access to it? And if they don't have it in their communities, what resources do they have to safely travel to get those treatments? Thank you so much.
So most of the critical access hospitals around the state in our rural communities have these drugs. Most rural communities actually have better access than our urban areas, places like Anchorage, Matsu, Fairbanks, Kenai. A medical provider has to administer them, these drugs. The Regeneron product, Regen-CoV, is being supplied at no cost by the federal government. So your local healthcare provider or entity would have to reach out to us at the state and ask for some, and we'll send them to you. In terms of further access than that, I recommend calling our call line.
All right, thank you so much, Dr. Cutchins. So any updates on new symptoms presenting for those testing positive for COVID-19? In particular, people are asking about earache and sneezing as symptoms for COVID.
Dr. Demain, do you have any thoughts on this from a clinical perspective?
Yeah, I'm happy to address that. Well, individuals that have a viral infection, whether it's COVID or other viral infections, it's going to concentrate in the upper airway. So when you have congestion in the upper airway, it can decrease the effectiveness of the eustachian tube to clear or to equalize pressure. So that can definitely cause ear pain. because the pressure doesn't equalize. Oftentimes with viral infections, they can develop fluid behind the middle ear. It's not dangerous, and it gradually will go away. Sometimes, unfortunately, that can become more of a bacterial infection if it's there for a prolonged period of time and may require additional therapy like antibiotics. As far as sneezing and other nasal symptoms, I think that would be common with COVID as well as any viral respiratory infection. And right now we're in RSV season. Those symptoms are common with respiratory syncytial virus. So it's not necessarily COVID, but if you have symptoms, check to see if it is COVID, and if it's not, again, it's likely one of the other respiratory viruses that we're seeing in the community. Hope that helps.
Great, thank you.
Excellent. Dr. Cutchins, I see here that you flagged this question to answer regarding ivermectin and studies about its use as a treatment for COVID.
Sure, I'll try to keep this relatively short, but I could probably talk about this for a long time. So ivermectin, is an old repurposed drug. Early on, it was thought to be possibly effective due to the against the COVID-19, the SARS-CoV-2 COVID-19 virus. Unfortunately, it was really only shown effective in computer modeling. The stage that we look at for these drugs is first you do computer modeling to see if drug is effective against virus. Next, you move on to tissue samples to see like what concentrations the drugs have to be. Next, you move on to see if they're safe and effective in people. I will say, I've talked about this before with vaccines. The pillars in the US here is drugs have to be proven safe, but they also have to be proven effective. And this really goes back to the snake oil salesman we had 100 years ago that made a lot of claims. So with ivermectin, we actually have quite a lot of data right now. There was a big study done, and I'll point to reliable resources because there are some false medical resource websites that are unfortunately very convincing. But I'll be happy to, let me talk a couple of things. So this study, Joe, can you see my Cochrane review?
Yeah, if you can blow it up a little, Coleman, that might be helpful.
Try. Okay, so for this one, this is a Cochrane review. So these are really the highest powered summary. So what they do is you look at a lot of studies that kind of look at the same thing, combine the results, put them together to figure out a more powerful view of what's happening here, because most of the trials that have been done, either they didn't they cherry picked their patients. In one group they may have picked a much healthier group, and the other group it was a less healthier group, so the intervention, you can't really know if that was due to choice. A lot of the studies that are done in India and Asia. Actually, we're comparing ivermectin to a drug combination that we know is unsafe, the combination of hydroxychloroquine and azithromycin. When we have hospitalized patients on both of those drugs, we monitor their heart for arrhythmias. It's a dangerous combination of drugs. So in those studies where you were comparing ivermectin to what we know is a dangerous combination, you can't really say that better outcomes were due to the people on ivermectin. So this one really is looking at all of that. It bunches them all together. I'll put it in chat. It powers things based on if there were bias, can we generalize the studies? The big takeaway though is, this looks at really all of the studies that are out there, peer reviewed, published in medical literature. The conclusion is based on the current very low to low certainty evidence, we are uncertain about the effectiveness and safety of ivermectin used to treat or prevent COVID-19. The completed studies are small. Very few are considered high quality. Several studies are underway that may produce clearer answers. Overall, the reliability of evidence does not support the use of ivermectin for treatment or prevention of COVID-19. I've been monitoring the studies that are underway. A lot of them are actually dropping. I think it's due to the fact that we're just getting overwhelming evidence now that unfortunately this is not a treatment. The Infectious Disease Society of America, which are really like our experts in this country on the treatment of infectious diseases, they do guidelines for things like pneumonia and urinary tract infections and skin and soft tissue infections. And really this is the organization that the leaders in infectious disease. It's what the doctors who specialize in infectious disease follow, kind of their governing body. They have a very similar statement on ivermectin. They quote, they show you all of the studies they've talked about. Here they recommend against ivermectin outside of clinical trials for both hospitalized patients and ambulatory. NIH guidelines is the same way. They recommend monoclonal antibodies for outpatient. That's really our only drug therapy that we have good evidence around. Another thing I'll point out on ivermectin is, so Merck is the drug company that actually owns the patent of ivermectin here in the US, and they're one of 2 manufacturers that make the drug. So the manufacturers have to be licensed with the FDA as well to bring drugs into the US. So we only have 2. Merck have straight up said they don't have a scientific basis for potential therapeutic effect, and they have no meaningful evidence for clinical activities to continue to study it, and a concerning lack of safety data. So I'll get on to safety data now, because this is really where my own personal concern is. I've done this a couple of times on here when we look at drugs, and we have a concentration and we have time. So when ivermectin is given for parasitic infections, we give 1 dose and that's it. It's a 1-dose drug. You give 1 dose 1 time. So it kind of looks like this. We give a level and it's eliminated. These ticks are about 20 hours. So if we take 1 dose of ivermectin for scabies or roundworms or hookworms, which it is indicated in humans for that, it's this once dose. It's gone from our body in about 80 hours. What these, kind of fake medical guidelines are recommending is really high doses for multiple days. So if we're taking like 4 times the amount, we end up way up here. I'll kind of even do it to scale so you can see the difference, because you end up with much higher levels. So for worms, we would take it at a level like this and it would be gone. What they're recommending, when you take a dose that's 4 times higher, you get up here and then you eliminate. You take another dose, you get up here and you eliminate. You take another dose, you get up here, and then you end up kind of reaching this thing we call steady state. So in the doses that we've studied it under, think about it, this is the maximum amount that ends up in your body, and this is how much your body is exposed to. In these other regimens, you're getting this maximum level, and this is the amount of drug that your body is exposed to. So it really, really changes the safety profile of these drugs when we don't take them in the way that we're studied. Now, the last thing I'll kind of talk about this is, in the initial studies that these websites are quoting that showed ivermectin to be beneficial, it's at a very high concentration. Actually, we'll say about here. When we give ivermectin for worms in people, we only get about this much compared to that level. The way antibiotics work is you actually want to get enough above the level to where you have a long time where you're above that, because this is the effect you have at killing things. So at this really low level, we're not even coming close to the level of what we were seeing in labs for it to inhibit the virus. So it's just kind of this side of it, the kinetics paired with the data that we have at this point, that it's not showing beneficial, in things like our Cochrane review. It's not a treatment that we have evidence to support. So at some point though, I'll be honest, if there's 3 or 4 of these big trials that come out and show that it's beneficial, I will stand right here and tell you we have evidence to support it. The Infectious Disease Society of America will probably change their guidelines. Sorry to kind of talk for a while about it, but I hope that was helpful.
Yeah, no, appreciate it, Coleman. That's a really important topic. There's a lot of confusion about it because there's so much misinformation and wrong information that's being circulated on social media sites and other websites. So really appreciate you taking the time. Let's go ahead and move on to the next question, Erin.
Yes, absolutely. So there are actually a few quick follow-up questions related to ivermectin use. The first being, some of the examples of some of the more severe effects of improper dosage in these higher amounts. And then also questions that we've received asking if these drugs do present a danger, why are we seeing an uptick in prescriptions?
So some of these medical misinformation sites are very convincing. There's one of them that unfortunately is fooling doctors into thinking that it's a legitimate site. I have talked to a few providers about it and they're like, wow, I didn't know, I didn't think about this. They can be very convincing. There are also some physicians who are in it for financial gains. I mean, we're hearing about physicians who are doing telemedicine consults and charging people $100 to write a prescription for ivermectin from some other state. and that's unfortunate. So the other thing I'll say about toxicity is ivermectin is a drug that crosses into your brain at high concentrations. We talk about the blood-brain barrier in drug delivery. So your brain is sort of protected by this layer that stops blood from getting in, and not all drugs cross into your brain. Ivermectin does at higher concentrations, so you can overdose on it. Overdoses, we see things like confusion, seizures, severe gastrointestinal discomfort and distress. And the question about pharmacies. If the system of prescribing and dispensing drugs is a checks and balances system. Not one person does it most of the time because we want to check each other's work. So pharmacies have a lot of limits, and they have a 50-50 shared decision-making and liability in drugs getting dispensed. So like to dispense a drug at 4 times the usual dose for 5 days longer than or 10 or 15 days longer than usual therapy, no matter what the drug is, like most pharmacies will probably not dispense that drug and have a discussion with the provider because it is a safety concern. And so much of that, we really talk about evidence-based medicine, what does the evidence approach us to? So, and unfortunately, a lot of people are going to veterinary preparations, which can be bought, over the counter out of a mill and feed store or things like that, which is another safety concern. So I hope that answered all the questions.
And we are hearing from a number of states that a large proportion of their poison control center calls are due to people who are overdosing on ivermectin. So please steer clear of ivermectin. And, as Coleman said, if there's new information that comes out in the weeks or months ahead that suggests it might be helpful on some level, then we will certainly relay that to you. But at this point, all the evidence points away from ivermectin as being a helpful medicine for COVID.
And the last thing I'll mention on it is we do have treatment options. So, for people that test positive early on, monoclonals are a beneficial treatment option. So if people are taking a drug, even if it was at a lower dose that wouldn't be harmful, we also want our drugs to work. So it's that proven safe and proven effective side of it. So that's kind of the last thing I'll mention on it.
All right, moving on to some questions related to monoclonal antibodies. What is their availability for children who have COVID?
So monoclonal antibodies are indicated for children 12 and up who weigh at least 40 kilograms. So under 12, under 40 kilograms, they're not indicated for that group at this time.
Okay, and is there any advantage of IV over subcutaneous in terms of administering monoclonal antibody?
So the statement that Regeneron is giving is that IV is preferred, but if it would delay treatment at all, subcutaneous. So the way I explain it to people, if you can give IV right now, go ahead and give IV. If it would delay even an hour, give subcutaneous. When we think about monoclonal antibodies, drug class, it's been around for about 15 years. Some of them are given subcutaneous. There's been a lot of research on how they're brought into the body. We don't see any clinical difference in terms of subcutaneous versus IV in other monoclonal antibodies.
All right, switching topics just a little bit here. For folks who are concerned that they might be immunocompromised and eligible for the 3rd dose of the series, what qualifies them for that 3rd dose, and what documentation, if any, do they need to provide to a practitioner to receive that?
Great, Matt or Lisa?
I'm happy to take that question. So for completing the 3rd dose series for immunocompromised individuals, there's no doctor's note that is needed. Individuals just need to self-attest to being immunocompromised to receive that 3rd dose. So we want to remind providers that we're trying to not miss opportunities or put up barriers. So individuals just need to self-attest to being immunocompromised.
Great, Matt. And I wonder if you could go through the criteria that CDC had posted in terms of who qualifies for as having moderate to severe immunocompromising states. I think that was out on CDC's website.
Yeah, so I don't know those off the top of my head, so I'm going to call out a lifeline. And Kelsey, do you have those? Otherwise, I can pull those up quickly.
Let me pull them up and we can make sure we put the link in the chat also.
Okay, great, thank you.
Awesome.
Back to you, Aaron.
All right, great. So any recommendations for process and isolation for essential workers that differs from what presently is recommended today? Our participant says that they haven't found any information regarding that in months. Is the present focus more on vaccinated versus non-vaccinated right now rather than these mitigation strategies? Thank you so much.
Great, Louisa, do you want to take a stab at that one?
Sure. Was the question sort of about critical infrastructure, or was it more just about healthcare workers?
Yeah, so specifically, isolation for essential workers that might differ from the general population or other sort of mitigation strategies to prevent the spread of COVID.
Yeah, I think in our testing guidance, there's, if you look in some of the tables, there's information about isolation and quarantine. And then there's also a link to, it's very specific to seafood processors. And then I think there's also a link to healthcare workers. So I think those categories sort of have a little bit of special parameters. I mean, I think in general, back to critical infrastructure, a lot of the information was about how to mitigate risk if you had workers that really, for the safety of like operating a boat or operating something that needed to go on, that there was personal protective equipment that could be used and measures taken to minimize contact with other folks. And I don't know that any of that has changed. That's still in place to minimize risk in those situations. There is, because there's vaccination status now that you can take into account to have that as another layer with that mitigation, that can be considered as well. I don't know that there's anything specifically written out. I don't know if others are aware. And I don't know, honestly, if what's on the website to help with that beyond just the testing guidance and then some of the informational flyers, but would request anyone who has other information to chime in.
Yeah, maybe we can, I think that sounds great, Louisa, and maybe we can just put the testing guidance link in the chat box.
Excellent, thanks so much. Kelsey, I see that you've responded with some of the CDC guidelines regarding those third dosage for immunocompromised folks.
Yes, so the list that's specifically written out on CDC's website has been receiving active cancer treatment for tumors or cancers of the blood, received an organ transplant or taking medicine to suppress the immune system, received a stem cell transplant within the last 2 years or taking medicine to suppress the immune system, moderate or severe primary immunodeficiency such as DiGeorge syndrome, Wiskott-Aldrich syndrome, and then advanced or untreated HIV infection, active treatment with high dose steroids or other drugs that may suppress your immune response. But really the bottom line is that this list is not exhaustive. These are examples of what really could put you into this category, and that CDC definitely recommends people to talk to their healthcare provider about their medical condition and whether getting an additional dose is appropriate for them.
All right, thank you so much. So we have a participant who shares that unfortunately their 6-year-old caught COVID at school last week. They ask that once their child has recovered, are there any pediatric specialists in the state that they can take her to for a thorough examination? This parent shares that they're especially concerned about their child's heart and lungs.
Great. Dr. Nace, would you like to take that?
Yep. Sure, I can take that. There are going to be quite a few children in that same condition that are now positive and have been treated. And the recommendation is that they should be seen post their 10-day isolation period to have that review and talk over with their provider. It doesn't have to be a specialist initially. It can be their pediatric or their family practice provider that they normally see to discuss the concerns. At that time, they'll determine, yes, you would be qualified, or you would be a concern that we would want you to see a cardiologist, and that kind of decision can be made. But the first step is just reaching out to your regular provider and getting that initial evaluation and test and talk about what should come next.
All right, thank you so much, Dr. Nace. Some questions related to flu season, in addition to what we're experiencing presently with the COVID. Namely, any advice concerning when to schedule flu vaccination along with a COVID booster? Should they be administered with a time lag in between or administered on separate arms? What are the current recommendations? Thank you so much.
Great. Matt, you want to take that one? Matt or Kelsey?
Sure, I'd be happy to start with that. So just for everyone to know, boosters are currently not recommended for individuals. So FDA is currently reviewing studies and looking at that data. And so once FDA authorizes boosters, then it will be up to the Advisory Committee on Immunization Practices, the ACIP, to then recommend that. We've heard from our federal partners that we can expect those recommendations to come out around September 20th. In terms of receiving an influenza vaccine shot with a COVID-19 vaccine, these vaccines can be co-administered, so you can get them at the same time. And so what we're trying to do is to get our COVID-19 vaccination providers to also, if we can, get them to also carry the flu vaccine as well. And so we're working on getting that going. In terms of receiving the flu vaccine, there is some recommendations from CDC that you should really receive the vaccine kind of September, October timeframe. If you're an older adult, 65 years and older, the recommendation is to receive that more late October due to waning. Kelsey, is there anything else you would add to that?
I would say that, we have seen that it is safe to have these vaccines administered at the same time. And, we never want to miss that opportunity to vaccinate. So these can be administered at the same time. And I think that there was a question about, whether it should be in separate arms or, spaced out by an inch in the same arm. And I think, what we've seen that really the recommendation is to have them in separate arms. We are trying to watch for those adverse events or swelling, irritation around the injection site for specifically those COVID vaccines. But we're also very interested for other vaccines as well. So to make sure that we do have those accurate VAERS reports put in the system, having both of those immunizations put in separate arms makes that a lot easier to track which was which. So definitely get them at the same time if you're able to do so, and so that you're protected this flu season.
Thanks so much. Matt, you just touched briefly on boosters and how they're not yet authorized, but we anticipate that they will be, relatively soon. Can you speak a little bit to the state's present efforts to prepare for when those eventually do get rolled out? And what can the public expect?
Yeah, so right now we are working on getting prepared for booster shots. Hopefully by September 20th, again, we're monitoring what's going on at the FDA and Advisory Committee on Immunization Practices. So we have formed a lot of work groups. And so what we are doing is kind of, if you remember, kind of when we started rolling out the vaccines, and we had specific populations that we were trying to target. So we want to reach those populations again. And so, for example, healthcare workers who are kind of at the front line, and we know that they were the first to get vaccinated. So we want to make sure that they can also get the booster, as well as kind of our harder to reach populations like long-term care facilities. How do we reach those individuals as well as our older population? And so we're really trying to form in these work groups of how can we reach out to all of these individuals again. And so we'll definitely keep everyone posted on kind of any information and kind of what we develop, but those plans are definitely being worked on.
Okay, we've received a few questions related to testing. Team, have we seen an uptick in COVID tests administered over the summer surge? And what are testing numbers and results like presently compared to last year's November big wave?
So a few things. So unfortunately, the entire pandemic, we've really been talking about, flattening the curve. We don't want everyone to get exposed and infected all at once, because then it overwhelms all of our systems. It overwhelms our testing, it overwhelms our vaccine, it overwhelms our hospitals, it overwhelms our clinic. here in Alaska, a lot of our communities are unfortunately experiencing the highest numbers they've experienced the entire pandemic, as well as a lot of places in the lower 48. Fortunately, we're still in a pretty good spot for testing. A lot of states are reporting that they're back to like 7 to 10 day turnaround times for lab tests. Unfortunately, we've had some long lines, but we're still getting most of our test results back in 48 hours-ish, which is pretty amazing. The long lines are really, from talking to the communities, specifically Anchorage, Fairbanks, Mat-Su, the long lines are really a result of a few things. A large surge, but also a lot of people that are unvaccinated that are being required to test instead of being vaccinated. So we have, those are kind of the compounding things that are really affecting our lines. The other things is just like when we talk about hospitals, staffing is the issue. It's hard to get enough staff to run these drive-through test sites. It's hard to get enough staff right now to staff our hospitals. So, anything we can do to flatten the curve. But I will say, even with all of that, if you have any symptoms, it could be COVID, please go and get tested. The other thing that we are really working on at the state is to secure rapid testing resources. Many states are completely out of them. We've always been one of the most tested states. We've been hovering 2.5 to 3 times the national average, which is great. And it's great that people go out there and get tested. But does anyone else have anything to add on that?
No, I think you covered it. Thanks.
Oh.
And Louisa, Louisa.
Yeah, no, I was just going to say, as far as testing volume, I mean, I don't know, about a month and a half ago, we were looking at maybe like 4,000 to 5,000 tests a day. And I think this week we're looking at like 12,000 to 13,000 a day. So the volume is definitely increasing. As Coleman mentioned, there's a bunch of different folks seeking testing. In addition to Alaskans, we're having a bunch of people move in and about the state. There's cruise ships, there's all kinds of other testing going on. So it's not necessarily just, it's not sort of that same finite population, but the numbers of tests are definitely going up, and you can see the percent positivity is kind of fluctuating as well, but there's definitely a lot more testing activity.
All right, can we talk a bit about, I'm sorry, Dr. Nace, did you have something to add?
Yes, I was just going to say there's still some confusion about that. There are a lot of requirements to be tested before you can return to things such as school, the difference between the antigen and the PCR testing. And so the schools are requiring the PCR. So some people are still doing the home or the antigen testing, and those are not the ones that are required to be able to go back to school if you're symptomatic.
And could we briefly touch upon the differences between the PCR tests and others?
So there's a question. I thought, Jamie, do you want to talk about PCR versus TMA?
Sure. So TMA and PCR are very similar. Polymerase chain reaction is what PCR stands for. It uses a DNA polymerase to generate enough of the genes there so we can detect them. TMA is similar in fashion. It only uses one temperature, but it uses RNA polymerase. It's a very different enzyme, but it generates the same sort of amplicon so we can detect it. The biggest difference between PCR and TMA is the TMA is much more sensitive, sometimes 900 to 500 times more sensitive than some of the tests that are being offered out there. So if you have the opportunity to use a TMA, I would go that route. It doesn't mean that PCR is not the golden standard and it doesn't work anymore, because it does. We have both of those capacities here at the State Virology Lab and the Public Health Lab in Anchorage, just so that we have enough capacity to do as much testing as we do. I think you're seeing more TMA testing being offered because the company that offers that has solved some of their supply issues. And so we're able to offer that test more broadly. Go ahead, Coleman, if you have other things to say about TMA.
Yeah, I will say a lot of commercial labs have switched from PCR to TMA for 2 reasons. One of them, the one that Jamie hit on, is that they actually are better performing most of the time than PCR. They detect a lower level of virus. Another advantage is they're less labor intensive to run. These are kind of like what you think of as like a walk-away test. So you start the samples, you hit start on the machine, and you walk away. So a lot of high throughput labs are switching from PCR to TMA, now that those supply chains are resolved, and it's really a better tool in some ways.
Okay, Dr. Nace, you did touch upon some of the differences between the tests that schools might be requiring. Any recommendations for at-home tests for parents or other folks to purchase? I believe you're on mute.
That's Coleman's area. I was just.
Oh,
I
take
I
that
will
one.
say that for the at-home test, there's a lot of different kinds. So there are molecular tests that are observed. You do them on like a FaceTime encounter like this, and those would be an acceptable molecular test to return to school. They do have to be swabbed and sent to lab. So you have to live in an area with good access to overnight FedEx or UPS. And then there's also some that we call more over-the-counter tests. These are tests that you run the test yourself, not under observation. The data doesn't get reported. Though that's kind of an evolving area, but it's just important to use those tests the way that they're supposed to be done. A lot of them give you 2 tests, and 2 tests are really meant to be 1. And the way that works is if both are negative, then you're 80–90% sure that you don't have COVID. If one of the 2 is positive, you're positive. If both of the tests are positive, you're positive. So it's kind of a 3 options for positive, 1 option for negative. And just, I really encourage everyone, if you're going to use any of those, read the directions carefully.
Excellent. Thank you so much, team. Let's talk a little bit about some trends. We have quite a few questions that are asking what the experts here are seeing in terms of transmission recently. Do we know anything about large events, maybe like the fair, for example, contributing to an increase in spread?
Louisa, you want to start with that?
Yeah, sure. I think there's COVID everywhere. You can see that the map is absolutely monochromatic red. So there is COVID everywhere. I think because there's COVID everywhere, if there is a signal from the fair, I'm not sure that we're going to see it because there's so many signals from across the state. People are having many interactions, and there's a lot of COVID everywhere. And we've sort of talked about this before. I mean, the mitigation strategies are to cut down on transmission. So those events where there are people in close proximity to other people, that's where we're seeing transmission happen. I don't know if there are other, I don't know if Sarah, you want to talk about specific clusters. I think there's just so much activity. And when there is so much activity, people can have 3 or 4 exposures, and maybe they were at the fair, but maybe they were at a birthday party, or maybe they were at school, or what have you. And it might not be clear where their source of COVID was because there is just so much activity.
Yeah, I would agree, Louisa. There's not just the fair, but there's just people are a lot more active than they were, a year ago this time. So it's a much more transmissible variant, right? So we know it's, twice as transmissible as the original. So COVID is everywhere for sure. But the same mitigation measures that we used before do help and reduce risk, that layered approach that Dr. McLaughlin mentioned at the beginning. Your vaccination, masking, social distancing, good ventilation, those all make a difference.
Thank you so much. So now some questions related to breakthrough cases. Some folks are wondering about trends there, anecdotally experiencing maybe a lot of friends and family who are reporting breakthrough cases after vaccination. Some participants are wondering if there is, if that is evidence of a decrease in vaccination effectiveness, or perhaps a difference between different vaccines. Could our experts speak to that, please?
Great. Yeah, I think a number of us could speak to that. I don't know, Anna, do you want to start with that, or I could?
I don't usually cover. I don't usually cover breakthrough, but if you want me to, I can.
No, I'm happy to. I was just thinking maybe we can pull up our breakthrough report, or our most recent report as well, and we can kind of go through that. So vaccine breakthrough is increasing, as I mentioned early on in the slides. This is due to a number of different reasons. One of the reasons is we've got a variant that's much more transmissible, and so more people are being exposed to the virus as we start to see case counts increasing, and it takes less exposure, fewer virus particles that you're exposed to become sick. So that's probably playing into things. We're also seeing waning immunity over time among people who have been vaccinated. So the longer it's been since your vaccination series has been completed, the more likely you are to have a breakthrough infection. Also, we know that waning immunity tends to occur much faster in older people than younger people. And unfortunately, the older people were, by and large, the ones who got the vaccine first. And so that's playing into things. The other thing is, as the proportion of the population that's fully vaccinated increases, the proportion of the cases that occur in a population that are vaccine breakthrough is going to increase. So if you've only got, let's say, 5% of the population that's vaccinated and there's virus circulating, you're going to see small numbers of vaccine breakthrough cases if everything else is remaining stable. But as that proportion increases, it's just a larger pool of people who are in that vaccinated group who are going to be contributing to vaccine breakthrough cases. So you're going to see that affect things as well. The other thing is, as our population becomes more vaccinated, that is increasing, and then the proportion of the population that's unvaccinated is decreasing. And so as that decreases, then the total number of people in the population that are susceptible because they're unvaccinated goes down. And so that's also going to contribute to vaccine breakthrough cases. So there are all sorts of factors that contribute to this. And we have, and maybe Anna has put it in the chat box, we have a report that we put out, I think about a week ago, that takes a look at our vaccine breakthrough cases. And the second paragraph in the discussion goes through all of what I just relayed. And so really encourage folks to go ahead and take a look at that. Great, thank you.
Dr. Castrodale, were you wanting to?
So I just, as Anna was, or whoever that was, scrolling through, I think that one graphic that really breaks things January to June and July is super helpful. I mean, I think the take-home message from this is, wait, that one, no, the other one, the big fat bars. Yeah, what this is showing is from January to June, the folks in blue were not fully vaccinated versus the folks in green who are fully vaccinated. So the folks in the unvaccinated, not fully vaccinated folks were 16 times more likely to be hospitalized than those who were fully vaccinated. And so that was very impressive. That's what we were seeing, really like a decrease in cases, a decrease in hospitalizations. And July, as Delta has sort of taken hold, there's still an incredible protection that's given with vaccination to that risk of hospitalization, but it's a little bit, it's muted, you know, it's only 8 times, but 8 times the risk of hospitalization is still pretty impressive. So as Joe mentioned, you know, we in the nation and the world are sort of continuing to watch what happens with Delta and what happens with vaccine effectiveness, but there is still incredible protection from these vaccines.
All right, thanks so much, Dr. Castrodale. So we're nearing the close of our session. I'll turn it over to our hub team for any final thoughts or updates that they'd like to share.
You know, Erin, this is Joe. You know, one of the things that I did want to share is some recent studies have come out, and I'm sure many of you have read about these, suggesting that infection-induced immunity might provide equivalent or superior protection against repeat infection when compared to the risk of breakthrough infection from vaccine-induced immunity. And so the question comes up, if so, does this mean that it's better to get your immunity through infection rather than through vaccination? And the answer is no. While there is considerable immune protection that comes from natural infection, it could come at a big cost. This is because the risk of serious harm to your health is substantially higher if you get infected with the COVID virus than if you get your immunity through vaccination. So it's much, much safer for people to get their immunity through vaccination than to get immunity through COVID infection. And there was a study that came out in the New England Journal of Medicine last week that I didn't get to share with you all last week, but I want to share with you really quickly now, and I know we're almost out of time. But this study basically looks at vaccination in blue versus SARS-CoV-2 infection in yellow, and the risk ratio, so the risk of getting any of these adverse health consequences if you get vaccinated versus if you get SARS-CoV-2 infection. So you can see, and this is a risk ratio, so you can see about probably a 15-fold increased risk of acute kidney injury if you have SARS-CoV-2 infection Vaccination actually gives you a protective effect because it's below that dotted line there at 1. Appendicitis about equal, arrhythmia, much higher risk of arrhythmia, abnormal heart rate, deep venous thrombosis, clots in your legs, for example, and other veins in your body, much higher risk, 3-fold increased risk if you get SARS-CoV-2 infection than the general population, whereas there's no increased risk if you get vaccinated. Slight increased risk of herpes zoster infection and getting a zoster flare-up. If you've been vaccinated, it's just above 1 there. No increased risk with SARS-CoV-2 infection. Intracranial hemorrhage, that's a brain bleed. You're looking at about an 8-fold increased risk of a brain bleed if you get SARS-CoV-2 infection, and a decreased risk, actually a protective effect, if you get vaccinated. Swollen lymph nodes, you're going to have higher likelihood of having swollen lymph nodes after you're vaccinated. Heart attack, myocardial infarction, there you've got about a 4-fold increased risk of a heart attack if you get SARS-CoV-2 infection compared to the general population. No increased risk if you're vaccinated. Myocarditis, this is one of the big issues that's come up. What about myocarditis and vaccination? There is about a 3-fold increased risk of myocarditis if you get the vaccine, but there's about, I don't know, is that over 20-some fold increased risk of myocarditis if you get COVID infection. So your risk of getting myocarditis is way higher if you get COVID infection based on these medians. Pericarditis, inflammation around the heart, here you're looking at about a 5-fold increased risk and no increased risk that's statistically significant for vaccination, but 5-fold for if you get COVID infection. And then lastly, pulmonary embolism, which is a clot in your lungs, about a 10 or 11-fold increased risk of pulmonary embolism if you get SARS-CoV-2 infection, no increased risk if you get vaccinated. I hope this information provides incentive enough for any of you who are still on the fence about vaccination to go ahead and get vaccinated. And I'll provide that link in the chat box. That's it for me. Thanks.
Excellent. Thank you so much, Dr. McLaughlin. I know that we're out of time here today, but I did want to point out that there are quite a few questions in the chat about some of the details with the vaccine breakthrough data that is provided by the state. For folks who have questions about that data, would like to tease out some of those details, who can they contact? And is that a contact information that can be shared in the chat to our participants?
You know, I would start out by saying if you have questions about that, these echoes are a great way to get those questions out and get them answered. And if you submit your questions early, then we know that we're going to be able to get to them. So I would say that that's a great way to do that. Louisa, any other thoughts on that?
Yeah, I'm not sure if it's we're sort of channeling things to the public information folks because they get a ton of questions and they sort of get answers on certain things and can maybe be efficient in kind of putting some answers out that they to repeated questions. So I don't know, Elizabeth or Clinton, if that sounds reasonable for sort of focusing questions. I'm not sure. What do you think?
Well, there's always the COVID questions that'll ask.
Oh, brilliant. Do that. Let's do that.
So I'll put that in the chat box. And, you know, that's the general public question email. But, you know, if you have a suggestion for a media echo, we can route it that way too.
Okay, excellent. So participants, please keep an eye out for that information in the chat box. All right, final thank you to all of our folks joining us today, as well as our hub team. And then just a general notice, the state of Alaska and Center for Human Development are conducting a survey on access to COVID-19 vaccines for people with disabilities. So we would love to hear from adults with disabilities or family members, caregivers, and disability service providers. I've shared a link to that survey in the chat. If it's relevant for folks to fill out, please do. If you know of others who would be interested in filling that out, we invite you to share that information with them as well. All right, again, thank you so much for attending today's Public Science Echo and for joining this, dialogue, this important, time together that we have. Our next session in this series will be next Wednesday, September 1st from 12 to 1 p.m. And please remember to visit the shared box folder to access videos and resources from all echoes in this project, including today's. Thank you so much, and we'll see you next week.
Great, thank you, everyone. Bye-bye now.